Excellent.
Thanks everybody for joining another session from the Royal. And this afternoon or evening, we're going to start talking about hydrocortisone and circulatory failure in preterm infants by the team from Japan. And interestingly, when I, 10 years ago read Professor Nakanishi's paper and Professor Kusuda's paper about this sort of happening of babies collapsing on sort of day 7 to 10 after life, I like, what are they talking about? What are they talking about? And they had like a 17% incidence. And slowly I start to recognize some of the babies they're actually talking about, which is really intriguing. I know the Japanese team have been doing hemodynamics hands-on daily for a long, long time. So I think that'll be a very interesting presentation. I'm going to hand over to Professor Kusuda to introduce his team and tell us about what's going on. There is some messages. Please turn yourself on mute, and please stop your video so there's better bandwidth for the speakers. Professor Kusuda, over to you.
Thank you, Coach. We are very glad to have this opportunity. So first, we have to appreciate Professor Julie Oe. I think she's just traveling right now. And also appreciate your effort, and Rahul always support us. So thank you very much this opportunity. So today, as Kurt said, we are talking about the use of hydrocortisone for circulatory failure, especially in micropremmies. So always we should think about the use of hydrocortisone in order to maintain circulatory condition in micropremmies. So four professors are going to speak about background mechanism and how to treat, and also how to use functional echocardiography. And also finally, what's the long-term outcome of the infant with adrenal insufficiency. So first, Dr. Masahiro Kawai, he's a leading pediatrician and also neonatologist, especially adrenal function in newborn infant. He's going to talk about adrenal function of micropremmies. So, Professor Kawai, start your lecture. Maybe start slideshow. Dr. Kawai, you are muted. You are muted.
I'm sorry. My name is Masahiko Kawai. I am from Kyoto University, Japan. I'm going to talk about adrenal function of micropremie today. At first, transient adrenal insufficiency of prematurity (TAP) is common in preterm infants born less than 30 weeks gestation. The majority of the patient presents within the first few days of life and rarely occurs after 14 days. This sentence is written by Dr. N.G. in 2016. But in Japan, late onset glucocorticoid responsive circulatory collapse (LCC) is also common. Main features of LCC is sudden onset relative adrenal insufficiency after the stabilized period without planned incidents. Main symptoms include hypotension, oliguria, edema, and increased oxygen requirement. In addition, administration of low-dose glucocorticoid is effective markedly. nationwide survey in Japan reported about 4% of VLBW infants require postnatal corticosteroid therapy after 7 days of life. As you know, TAP is an event during the early neonatal period. But LCC occurs beyond this period, and both condition is caused by a relative adrenal insufficiency. But you may think HPA axis of VLBW infants is already established before the end of early neonatal period, and relative adrenal insufficiency cannot occur beyond this period. So we decided to investigate the HPA axis of micropremmie at about 2 weeks of age. We compared the response to CRH tests in micropremmie between at 2 weeks of age and at term equivalent age. The main result is at 2 weeks of age, basal cortisol is higher, but the response to CRH test, delta cortisol was lower compared to time equivalent. Concerning ACTH, at 2 weeks of age, both the basal ACTH and the response to CRH delta ACTH both were lower than those at term equivalent age. Result of this study is in preterm infants less than 30 weeks of age, response to CRH tests at about 2 weeks of age is lower than that at term equivalent age. This suggests that preterm infants have a higher risk of adrenal insufficiency even at 2 weeks of age. In the next study, we investigated the characteristics of the response to CRH test of micropremmie with relative adrenal insufficiency, RAI. We performed CRH tests for the preterm infants who were suspected of relative adrenal insufficiency and compared them with healthy controls. In both groups, CRH tests were performed at about 2 weeks of age. Basal cortisol levels were not different. But delta cortisol was significantly lower in RAI group. In preterm infants who were suspected of relative adrenal insufficiency, the response to CRH tests were blunted. This suggested that clinical diagnosis of relative adrenal insufficiency in this study was confirmed by CRH tests. And relative adrenal insufficiency is not rare beyond first weeks of age. As a summary, in micropremmie, response to CRH is suppressed at about 2 weeks of age. These studies suggest that micropremmie is prone to relative adrenal insufficiency beyond early neonatal period. Why HPA axis of micropremmie is suppressed beyond early neonatal period? So in order to discuss this, I want to talk about the fetal adrenal development briefly. As you know, second trimester, during the second trimester, cortisol production is suppressed owing to the low activity of 3-beta HSD. But during the third trimester, cortisol production increases and cortisol surge comes prominent towards birth. So, do you think, how about the first trimester? Do you think the adrenal function of first trimester is much more immature than that of the second trimester? That's not true. During the first trimester, HP axis is already established and fetuses can produce cortisol by themselves. Someone might not believe this. Then let's think about the adrenal function of the patient with 21 hydroxylase deficiency. If fetuses cannot produce cortisol by CYP21 deficiency, excessive X induces hyperpigmentation, and excessive testosterone androgen induces masculinization in female fetuses. This fact indicates that HP axis is already established during the first trimester. Adrenal function is not immature in the fetus. Adrenal, during the first trimester, all the enzymes necessary to cortisol production is equipped in the fetus. This concept is clearly written by Dr. Goto's paper in 2006. Then, let's think about the function of cortisol during the fetal period. Cortisol is a hormone which stimulates cell or organ differentiation, but it suppresses cell growth during the fetal period. So, cortisol is necessary for the cell differentiation during the first trimester, and also necessary for the during the third trimester. But this is not necessary during the second trimester. Then cortisol is necessary during the first and third trimester, but not during the second trimester. And micropremmie is born this period. Fetus at second trimester is programmed to suppress cortisol production, and micropremmie may be programmed to suppress cortisol production. This is the last slide. As micropremmie is equivalent to the second fetus at second trimester, they might be programmed to suppress HPA axis. They might have a higher risk of relative adrenal insufficiency. This indicates the importance of glucocorticoid therapy for the micropremmie. Thank you very much.
Thank you, Dr. Kawai, for excellent presentation. Today we have 4 speakers, but we have a panel discussion after all presentations. So if you have specific question, please enter the chat panel. Right now, I don't see any questions. So let's move to the second presentation. Second presentation is while Dr. Masumoto is talking about management of adrenal insufficiency. So I think Dr. Masumoto can start your lecture right now.
Okay. Can you share my, okay. Can you share my slides?
Yes.
Okay. Okay. Good morning, good evening, everyone. And it's my pleasure to be here. And thank you for inviting me to speak to you at this meeting. So today I'd like to speak about management of adrenal insufficiency in micropremmies. Preterm infants are more prone to develop relative adrenal insufficiency in micro due to adrenal immaturity. And there is still no universal definition of RA in preterm infants, but most studies define this condition as a vasopressor-resistant hypotension that readily respond to glucocorticoid administration. The onset of RA typically occurs within the first week of life, but late onset cyclic collapse after the first week of life in micropremie is not uncommon. And downregulation of adrenergic disruptors has been implicated in the pathogenesis of pressure-resistant hypotension. Administration of hydrocortisone improves the cardiovascular status of patients with pressure-resistant hypotension. It's probably because glucocorticoid upregulates the function of the adrenergic receptor gene and promotes the expression of adrenergic receptors. This genomic effect of corticosteroids can explain the reduced need for vasopressor within 12 hours after corticoid administration. But more importantly, the beneficial steroid effect on the cardiovascular system is not only the upregulation of adrenergic receptors, but also the non-genomic effect of an immediate increase in blood pressure in 2 hours. As this graph shows, in preterm infants who receive low-dose hydrocortisone, there are rapid and sustained improvement in all elements of the cardiovascular status. The findings of this study are thought to be due to the wide range of genomic and non-genomic effects of steroids. Regarding hydrocortisone administration to preterm infants, I almost agree with the method described in Dr. Waterberg's review. I like this word "less is more" in the title of this review. And this review suggests 1 milligram per kilo as a first hydrocortisone dose. If the infant's blood pressure increases and cardiovascular status improves over the time frame, subsequent doses of 0.5 milligram per kilo can be given with a dosing interval of 12 hours for micropremmies. The actual dosage and dosing interval should be guided by the cardiovascular status of the infant. In Japan, many institutions administer 0.5 to 2 milligram per kilo of hydrocortisone based on cardiovascular status. And here I present the case of a preterm infant with LCC. A male infant weighing 656 grams was born at 25 weeks of gestation. The patient got a diagnosis of RDS during the transient period. The patient had no serious complication within the first week of life and on pressure control with equals to 0.28 at day 25. Blood pressure was 50 to 28 millimeters of mercury. Sodium levels are almost normal. However, the next day, the patient suddenly developed pressure-resistant hypertension. At the same time as the onset of hypertension, the oxygen requirement increased and chest X-ray showed pulmonary edema. After ruling out infection, PDA, NEC, and other causes of hypertension, low-dose hydrocortisone was administered. The blood pressure increased rapidly and pulmonary edema improved. This is a typical clinical picture of LCC. Definitive diagnostic criteria for LCC have not been defined yet because the pathophysiology of LCC is uncertain. But tentative diagnostic criteria for LCC were proposed by the Japanese study group for neonatal endocrinology, and I will explain it simply. LCC is a refractory hypertension that occurs suddenly after the first week of life in preterm infants. LCC is diagnosed after ruling out other causes of circulatory collapse, such as infection, massive bleeding, and NEC. Most infants with LCC respond to a low-dose glucocorticoid, and it suggests that the main etiology of LCC might be relative adrenal insufficiency. To elucidate the pathogenesis of LCC in preterm infants, a case control study was performed to compare steroid hormone concentrations between preterm infants with and without LCC. The result of this study was cortisol concentration did not differ between the two groups, but the total concentration of precursor in the pathway to cortisol production was significantly higher in the patient group. Our result indicates that preterm infant developed LCC because of relative adrenal insufficiency and excess stress. The Neonatal Research Network of Japan database shows that the incidence of LCC was 4% of very robust weight infants 50 years ago. But the incidence rate of LCC is increasing yearly, and it was to 5 to 10% during a recent 5-year period. The NR in Japan database also shows the incidence of LCC by gestation age. Around 20% of micropremmies receive glucocorticoid for LCC, and LCC was not seen in infant born at late gestation. This data suggests that maturity of the adrenal cortex in preterm infants related to gestational age, and infants with LCC have limited function to produce cortisol until the corresponding age of late gestation. And this is a chronological description of management of cardiac dysfunction in micropremmies using hydrocortisone. Micropremmies have a potentially low adrenal reserve and are more prone to LI during the early postnatal period due to excess stress. As the effect of hydrocortisone and dopamine on blood pressure is thought to be almost identical, it's reasonable to use hydrocortisone as well as volume expander and catecholamine to treat hypotension in this period. It is important to note that hypotension associated with RAI occurs not only during the transitional period, but also after the first week of life. as delayed intervention for LCC leads to the instance of severe neurological impairment. Hydrocortisone should be promptly used if response to volume expander and catecholamine for hypertension is poor. If treatment with hydrocortisone is effective, using vasopressin may be considered. And now, if I can briefly summarize the main points, micropremmies have a potential low adrenal reserve and are more prone to ALIA under excess stress. The precise pathogenesis of LCC is unknown, but the main etiology of LCC is ALIA. Timely use of physiological dose of hydrocortisone is recommended. Thank you for your attention.
Thank you, Dr. Masumoto, for your informative lecture. I do not see any specific question right now, so let's keep moving our presentation. Next speaker is Dr. Toshima. He's going to talk about functional echocardiography for hydrocortisone use. Dr. Masumoto, stop your sharing screen. Okay, thank you. So, Dr. Toshima, please start your lecture.
Yeah. Can you see it?
Yes.
Okay, thank you. Good evening. I'm Dr. Shima, Kanagawa Children's Medical Center. It's my great pleasure joining this meeting. I want to talk about tailor-made circulatory management based on the echocardiography in preterm infant, focused on hydrocortisone. And I had worked working same hospital for 20 years. I'm a clinician, so I would like to talk about my experience. I want to talk starting with our patient.
Stop. I think your slide is, I think this is the last one, no?
Okay, this
is last slide.
Come on. Sorry. Sorry, doctor. Professor. How about Dr. Costello?
Now I can see your first slide, so please start slideshow.
Sure. Dr. Chrysler, second. You can see second slide?
No.
No.
先生、一度スライドショーをやめて、まず先生のコンピューターでパワーポイントを立ち上げといてから共有した方がいいんじゃないですかね。
So the first slide and second slide. You can see second slide?
No.
No. No.
It's a first slide still.
Ah, 困ったな。
先生、さっきよかったら私の方でやってみましょうか。さっきの先生がメールで送ったのが最後ですよね。
そうです、そうです。すいません。でも、ドロップボックス入れてるのが悪いですかね。
共有中していただいて。
ドロップボックス入れてるの？
じゃあ什么？
これで出てますかね。
あ、OK。すいません。草先生、またお願いしていいですか。
はい。はい。
Please, second slide, please. This patient was our patient when I was parent in NICU. Gestation age 25-week body weight 760 grams. 1 hour after birth, body weight, body pressure, blood pressure 38/20. In Japan, many neonatologists check echocardiogram by ourselves. So we check echo, and that baby's ejection fraction, EF, was 46%, slight decreased. So we started DOA and DOB. 12-hour weaning of ventilator could be done. 24 hours, blood pressure increased to 50/30. 36-hour ductus arteriosus closed, good urine output. So I thought respiratory and circulatory states seem to be improved. But I was worried that the heart contraction had decreased after heart blood pressure had risen. EF 42% decreased with disorganized word movement, poor contractility. Next, please. Okay, thank you. 53 hours, she had neonatal seizure. We checked brain echo, and I confirmed IBH grade 3. 54 hours, a massive pulmonary hemorrhage, and she was dead at 55 hours after birth. This patient made me have the aim of preventing IBH. So we had working same NICU for 20 years. Next slide, please. As you know, hypertension is a risk of brain hemorrhage in adults patients. Blood pressure contain blood flow and vascular resistance. Please show upper illustration. Cardiac output. Preload is vascular resistance after load. Please illustrate lower slide. Vas constriction increasing after load. Hypertension patient has vas constriction increasing after load. That situation, blood does not reach the tissue organs. We called after-load mismatch in hypertension patients. Vas constriction increasing in after-load resist cardiac output, suppress cardiac output. That situation caused venous pressure increased, that caused congestion. We wonder, the congestion in preterm infant may cause brain hemorrhage and pulmonary hemorrhage. Please, next slide, please. Echocardiography in preterm infant can access the effect of afterload on the heart. First, upper panel, rate collected mean fiber shortening velocity, mean VCFC. That indexes means heart pump function, LV dimension and LV ejection time, heart rate. And on lower side, end systolic wall stress, ESWS, which is indexes of afterload. The ESWS, wall stress ESWS, and indexes of LV afterload is calculated from blood pressure, LV dimension, and wall thickness. ESWS attract me, and we would like to research afterload on the heart in preterm infant. Next slide, please. This slide shows serial changes of afterload and LV function in our hospital BLBW. In the left side panel, end systolic wall stress, ESWS, afterload. And right side, mean fiber shortening velocity, mean VCFC, LV pump function. X-axis shows hours after birth, 6, 12, 24, 36, 48, 60 hours after birth. As you know, the yellow line is IVH, pulmonary hemorrhage, PVL, complication babies. Blue is no complication babies. Systolic blood pressure and mean blood pressure changed over time toward blood pressure rise towards the 24 hours of life, but there is no difference between the two groups, with or without complication. On the other hand, left panel, the change in ESWS differs significantly between the two groups. The infant with complications had higher values at from 24 to 6 hours. The changes in mean VCFCs were opposite to the changes in ESWS. Till 24 hours, ESWS is increasing and mean VCFC LV pump is decreasing. Opposite reaction in preterm infant. Next slide, please. This slide shows stress-velocity relationship. X-axis shows the ESWS after load. Y-axis shows mean VCFC pump function. Look at green line, that is pediatric standard line. Yellow point is the VLBW point, and pink VLBW standard line in our NICU. There was significant correlation between ESWS and mean VCFC in preterm infant in our NICU. LV pump function of the VLBW can easily be suppressed by a subtle increase in afterload. LV dysfunction due to an excessive afterload may induce pulmonary or intraventricular hemorrhage because please red area, excessive afterload area. In our NICU, pulmonary hemorrhage baby, IVH baby is this area. Please, next slide. This slide shows the changes in the stress-velocity relationship before and after the use of DOB or nitroglycerin in VLBW. X-axis shows the ESWS afterload. Y-axis shows mean VCFC pump function. Blue line, increased mean VCFC. Drug improved pump function. Red is not increased, not improved mean VCFC. Please look at the left side, DOB cannot improve low mean VCFC with high ESWS. High afterload state DOB is a small effect in preterm infant. In contrast, nitroglycerin vasodilator used in elevated ESWS light panel can reduce ESWS and increase mean VSEP-C in 17 of 19 infants. Please, next slide. We suggest tailor-made circulatory management based on echocardiography in preterm infant since 2001. Catecholamine lies rapidly blood pressure and fluctuation blood pressure. On the other hand, hydrocortisone lies mildly and stabilize blood pressure. So at first, routinely, hydrocortisone 2 or 3 milligram per kilogram to all ELBW in day 1 in our NICU, just after birth. And additional use 12 hours after birth. And after infusion hydrocortisone, based on the stress velocity relationship. Please look at stress velocity relationship. Left area based on cardiac dysfunction with low ESWS. Left area, we use cardiotonic therapy. And blue area, right side, cardiac dysfunction with high ESWS, load reduction therapy, furosemide, morphine, PDA therapy. Without PDA, we use nitroglycerin. Vasodilator may dilate DA, so we check echo. Before using vasodilator, check PDA. Next slide, please. And we, as you know, the combination of hydrocortisone and the COX inhibitor may cause LEAP, intestinal perforation. Therefore, we don't use hydrocortisone after 24 hours of age. We use COX inhibitor to PDA and dilated LA based on echocardiography. We check echo and we use a COX inhibitor. Next slide, please. We are going to talk about this result. ELBW born at gestational age 23 weeks in our NICU for 20 years since start tailor-made circulatory management. All the survival discharge rate was 90%. Please look at figure. One to 2006, 78%. Since 2007, 93%. Since 2014 to now, 93%. Please, next slide. This slide shows circulatory management born at 23 weeks by tailor-made circulatory management. DOA, x-axis shows drugs, y-axis shows percentage drug using rate. Hydrocortisone is 100%, DOA or DOB were administered to 12%. In our NICU, hydrocortisone replaced catecholamine therapy. And the COX inhibitor, 77%. Next slide, please. This slide shows short-term outcome prognosis. Born at 23 weeks for 20 years. X-axis shows death and complication. Y-axis shows percentage. Severe IVH, 6%. Pulmonary hemorrhage, 6%. Late onset collapse LCC, 4%. Please, next slide. Change in character, so explain in our language. This slide shows development or intelligent quotient, long-term outcome. X-axis shows first bar 1.5-year-old, next 3-year-old, third 6-year-old, right side 9-year-old. And blue is normal development, and yellow is borderline development. Yellow is delay, less than 70 point IQ. In NICU, normal development accounted for 39% at 6 and 9-year-old. 1.5-year, 43% normal development. 3-year-old, 30%. And 6 and 9-year-old, 39%. I feel sorry. I cannot look at this slide. Please, next slide, please. In conclusion, the LV pump function in preterm infants can easily deteriorate when faced increased blood pressure with acute increase in blood pressure during the first few days after birth. Afterload mismatch may cause one of the cause IVH or pulmonary hemorrhage. Low-dose hydrocortisone replacing catecholamine therapy and the tailor-made circulatory management based on the echocardiography may reduce serious complication in preterm infant. I cannot, my slide not good. I feel sorry, but thank you for your kind attention. Thank you for Professor Kusuda.
Thank you, Dr. Toshima, for nice presentation. We have received a couple of questions, but time is limited, so let's finish all presentation first. So, final speaker is Dr. Nakanishi is talking about the long-term outcome of infant with adrenal insufficiency.
Okay, thank you for having the opportunity to make a presentation about the late onset sacral collapse and the long-term neurodevelopmental outcomes. How about my slides? It's okay?
Yep. Okay.
And Dr. Kusuda, how many minutes can I have for my presentation? or something. Okay. Okay, and today, Dr. Matsumoto and Dr. Kawai has nicely showed the detail of the adrenal function of prematurity and late onset cycle crops. And my presentation, I'd like to focus on the long-term neurodevelopmental outcomes and among extremely premature infants who suffered from late onset cycle crops. And first of all, I'd like to show you the typical case I experienced when I was a junior resident and who were treated with the steroid treatment in chronic phase. This premature baby, birth weight is 700 grams, and male baby. After he got through acute phase, he's getting stable with successfully weaning off intensive care treatment. But around 29 weeks of post-menstrual ages, he sadly shows oliguria and hypotension. And then we check rule out the infection or anemia on the PDA or hypovolemia, which might cause hypertension, but no findings of this kind of situation. And also we tried to the conventional treatment, but he did not respond to volume expander or blood pressure intraoral support. And also then I tried to use the hydrocortisone. After the hydrocortisone treatment, he dramatically improved the general condition like that. So the background of LCCs, Dr. Matsumoto has already shown the details. LCC is characterized by sudden systemic hypertension and oliguria after the first week of life among ELBW infants. And steroid treatment can dramatically improve the refractory hypertension. And underlying the cause of problems might be due to transient adrenal insufficiency or prematurity. And today's focus, my presentation is LCC is associated with abnormal neurodevelopmental outcomes. Okay, so here I will show the long-term prognosis of neurological development in preterm infants with LCC. We conducted single-center retrospective 1 to 2 case control studies among the infants born at or less than 32 weeks. We look at the prevalence of PVL, especially we focus on the postnatal PVL because LCC might affect the baby's brain injury like postnatal PVL. And also we looked at the prevalence of cerebral palsy. Here is the result. This is a long-term prognosis of LCC of infants, my single-center retrospective case control studies. Actually, there are no difference in the prevalence of chorioamnionitis or antenatal steroid treatment, which I didn't show the slides, and LCC infants compared to controls, a significantly greater incidence of postnatal PVL and CP. This is a single-center study, and it would be difficult to generalize those outcomes among LCC infants. Next slide shows a very important, interesting study. This is a retrospective multi-center cohort study by using the neonatal research network database from Japan. This study sample is large, about 3,000 infants born at 22 to 27 weeks gestation. So as shown in this table, LCC compared to the non-late onset LCC, LCC was independently associated as a risk factor for CP. The odds ratio is 1.5, and the neurodevelopmental delay at 3 years of age. This is a so large cohort study. So now the LCC was independently associated significant risk factor for CP, I think. So next, I'd like to talk about why LCC infants had poor neurological prognosis. So Dr. Washio from Tokyo Women's Medical University in 2013, at that time, he looked at organ flow pattern through echo examination at rate at LCC onset. He got some important findings. This slide shows organ flow pattern of superior mesenchymal artery and the anterior cerebral artery and renal artery. And here in the systolic phase and diastolic phase, you know, and in the superior mesenchymal arteries, in the diastolic flow is preserved, but on the other hand, in the anterior cerebral artery and renal artery, in diastolic flow is abnormal. This abnormal flow pattern at LCC so might be correlated with distributive shock, as shown in these echo findings. Furthermore, he looked at the cerebral anterior blood flow before LCC onset and at the onset of LCC. You know, the before LCC, the cerebral artery, anterior cerebral artery is preserved in the diastolic phases, but at the onset of LCC is in the diastolic flow is like collapsed, you know. But after the treatment of the hydrocortisone treatment, the organ flow pattern on the ACA is recovered. So hydrocortisone administration improves abnormal ACA flow patterns in this kind of patients. So this slide shows the timing of the onset of LCC infants from the study of my single center cohort studies. This is a post-menstrual ages at the onset of LCC, 26 weeks, 27, 28, 29, 30 weeks. This is a number of cases. You know, the LCC onset was mostly around 28 to 29 weeks of post-menstrual ages. That's the most vulnerable time for white matter injury. So I think that might lead to development of postnatal PVL and finally cerebral palsy at 3 years of ages. So considering those background, you know, now we have our independent criteria of steroid treatment as shown in the slides. Actually, this slide is modified from the original version of Dr. Masumoto in 2021. So, you know, the LCC is mostly accompanied by the worsening of lung condition. So when we think about the steroid treatment, we pick up the increased demand for oxygen treatment and lung edema according to chest X-ray. And also we check the electrolyte abnormality and oliguria and hypertension. You know, hypertension is very difficult to define. Some people pick up the systolic pressure of less than 40 milligram, or some people say that lower than the gestational age of something. Anyway, so we pick up those criteria, and also we evaluate the echocardiographic findings, as Dr. Toyoshima made the presentation. If the presence of more than 2 of the 5 signs above, then we think about the replacement dose of hydrocortisone. So actually, the ultrasound examination is very important, and in NICU, very common procedure among the neonatologists. We get used to do the echocardiography. Ultrasound examination is very useful for assessment of hemodynamic condition, RCC. This is the short axis view, which checks the ejection fraction very quickly and easily by the ultrasound examination. We check the like a PDF flow in short axis view, and we also check the several anterior cerebral blood flow like this. This blood flow is very good. Assessment of cerebral perfusion over time could be particularly effective in preventing PVL. So here is the strategy of the treatment in ELBW infants at Kisada University Hospital. As Dr. Masumoto has already shown, so I didn't show precisely about this. But anyway, simply to say that if any sign of symptom consistent with those criteria as shown before slides, we rule out this kind of condition by using the echocardiography, and then we do the primary treatment, mechanical ventilation, correct electrolyte abnormalities, and use the antibiotics if there is some infection. And also we do the cardiac support. If ejection fraction is decreasing, we start to use dopamine and dobutamine. And if they show the hypervolemia, we give the volume expander like this. If not, respond to conventional treatment as a verb. And then we consider administering the hydrocortisone. This dose is a physiological dose of the hydrocortisone. We sometimes repeatedly administer hydrocortisone between the two to 3 hours interval, like this. Okay, so my summary is here. LCC is associated with poor neurodevelopmental outcomes. Very important thing is that there are no curative therapies for PVL and CP. So LCC should be rapidly diagnosed and treated. And ultrasound examination is very useful for the assessment of hemodynamic condition in LCC. And in the last, replacement therapy by hydrocortisone. The dose is 1 to 2 milligram per kilogram per dose, can lead to improved neurodevelopmental outcomes among ELBW infants. Okay, thank you for listening.
Thank you, Dr. Nakanishi. So we finished all presentations. So we received several questions. So maybe we can continue the panel discussion as time allows. So back to Kurt.
Yes.
Please start this panel discussion.
Yeah, there's a couple of questions initially for Dr. Kawai, just looking at the fetal cortisol levels. And the hypothesis is that, the fetal cortisol levels are reduced during the second trimester. So if you're born during the second trimester, that will be how the preterm infant is sort of targeted, and what is right. So the question here is fetal cortisol reduction in the second trimester associated with placental endocrine parameters. That's what I'm assuming.
And thank you for the question. And I think placenta might be playing important role for to suppress fetal adrenal and axis, but maybe fetal itself will be programmed. So both fetus and placenta will cooperate. So I think.
So if, an ongoing question about that is, so if we then give antenatal steroids, do we as treatment affect those levels?
Okay, I agree that an IUGR or antenatal steroid will affect adrenal and fetal development. But I don't know, such effects could persist after birth or not. So we don't have a clear answer about the relationship between antenatal steroid and LCC or IUGR and LCC. So maybe we have to investigate a little more.
Yeah, I guess because, you know, the incidence, almost everybody will try to give antenatal steroids, particularly if born early, so it would be very hard to find that difference. But the second question is more related to the hemodynamics, which was described by Toyoshima, to say how we measure different aspects of cardiovascular compromise. You showed your data which did the relationship between pump function on one hand, on afterload on the other end. And the relationship was measured with M mode in short axis. Which is a rather classic way, I guess, of measuring these kind of parameters. They're much newer. Parameters in the field. So there's actually two questions. One is about, you know, should we just use these combination of pump function and afterload to target our treatments? And I think that's the first question. Do you use the combination of pump function and afterload to target your treatments? You're still muted. You're still muted. Professor Toyoshima, you're still muted.
Thank you. Thank you. Your question. We have corrosion, blood pressure increase, and pump function decreased. But permissive hypertension is important. And I respect to SVC flow. I respect to Nick Evans, and we check SVC flow same time. So output estimated by SVC flow and blood pressure increasing, we broadcast increasing blood pressure and deterioration of cardiac pump function.
It would be nice to see a graph indeed correlating these parameters, the M-mode parameters of pump function and afterload together with SVC. I think that would be very interesting data. I think the question here is also about afterload. Okay, so afterload in if you would measure it in an adult, is determined by 90% is systolic blood pressure. And I think what I learned from the talk and the message is we often talk about hypotension, but maybe it's just as important, and we should actually also find what is hypertension and when we should be way more careful with our support and actually try to indeed limit our increase in afterload which we create. That was one of the messages I got from there. There is another question which is about the hemodynamic effects of hydrocortisone from Nick Evans. Nick, would you want to unmute yourself and just explain?
Can you hear me?
Yes.
Yeah, I mean, when you look at the data of that Shabnori and Istvan Seri got with their studies of the hemodynamic effect of hydrocortisone, a fair amount of the effect on blood pressure was an effect on resistance, that hydrocortisone seemed to increase vascular resistance. And so I'm struggling a little bit with how to fit that in with hydrocortisone being a useful thing in the early period, when we're saying that afterload may well actually be an important factor in the cardiac compromise, which actually is an observation I agree with. But I'm just not sure how to fit that observation in. And I don't have a strong sense that we know hemodynamically what hydrocortisone is doing in this early period. I suppose that was really what I was trying to get at, that the data we have doesn't seem consistent with the fact
from Nick Evans, Dr. Nick Evans.
So I got and one more question, which actually was from Jan Kimek and myself actually as well, which was the LCC. So the late circulatory collapse. The data you present, it has an incidence or prevalence of around 10%, so 1 in 10 babies. Now, I do see every now and then a baby. So I guess it is there, it exists, but I wonder then if maybe the Japanese society is actually doing something different to their babies in the first weeks than we do. For instance, what I remember from some papers I read is that the duration of inotropic support, whatever it was, can be a week or 2 weeks, which would be very unusual. And I wonder if this catecholamine stimulation does something on the either adrenaline receptors or other sorts of receptors where hydrocortisone can be helpful. Would you care to comment on that?
Okay, so maybe let me comment first. Comment about the comment from Nick. Yes, you are right. Hydrocortisone actually increase afterload. So we always check the increase afterload. So if it increases too much, as Dr. Toshima mentioned, we can use vasodilator. So we sometimes both together. It's very strange, but sometimes we need. And second comment from Kurt. No, we don't know why we have this phenomenon. As you said, 10 years ago, we are stranger. Maybe we are so minority. But getting, I think, knowledge disseminated in the other NICU communities. But still, as you said, you don't have high incidence. So maybe we are treating differently first several weeks. Maybe we actually reduce the fluid infusion as possible, and also sometimes we use high frequency oscillatory ventilation as long as possible. And also, as you said, we try to continue catecholamine, sometimes very long periods. So maybe that's a comprehensive effect of this environment. But still, we assure us, even we are very careful, but some infant may show the FCC. So I'm not sure someone can add to my comments.
Dr. Kuseda, can I talk?
Sure.
Yeah, I'm Dr. Isayama from Tokyo. About the comment from the Dr. Nick Evans, I think the timing is very important. I think as Dr. Toyoshima explained, in Japan, we are changing the management based on the, how to say, the echocardiography, and usually just after birth, the problem is that many babies have struggling to adapting the newborn circulation. So many baby may develop the hypotension. So during that phase, hydrocortisone is very effective to increase the blood pressure, as you said. However, after that, usually 12 hours, 24 hours later, blood pressure improve. But at that time, the problem changed. That's timing. afterload mismatch become a problem for some babies. So based on the evaluation of the echocardiography and also blood pressure and the urine output, we have to change and we have to tailor our treatment based on the baby's condition. So at that time, if we think that after road mismatch is problem, we may consider the vasodilator or increase the sedation or adding the diuretics to reduce the afterload mismatch. So that's that I think changing. Hydrocortisone is not more like a treatment for the pump insufficiency or low blood pressure. Is that your answer to your question?
Go ahead, Nick. Guess he's multitasking. Look, this is a complex field, and the different hemodynamic situations which we encounter will be different for at day one. I think it's the same for all of us. At day 7 or day 14, I think it is partly dependent on what you have done as treatments to those babies. Hydrocortisone works on the adrenergic receptors. It can tone it up. But for how long it can tone it up, I'm not sure if there's any data which shows that in our little babies, particularly not the alpha adrenergic receptor. So there could be something there. There could be something in the actual presentation. Should you just ask you the question, what's the earliest finding on ultrasound in LCC? And from the pictures, I thought it was low blood flow. But can you clarify?
So who can answer this question? Dr. Nakanishi?
And sorry, and
what's the earliest?
So on the earliest, yeah, the earliest ultrasound finding. Is it low blood flow or high blood flow? What do you find?
I think the ultrasonography of the head is very useful to check this. That's the organ flow pattern. So I just estimate the blood flow perfusion in the brain. The the high blood pressure is very depend on the systemic. Cerebral blood flow is very depending on the systemic pressure. So, so for evaluating the cerebral blood flow is and the cerebral perfusion, it might be very easy to detect the organ flow pattern, especially in the anterior cerebral artery. It's not precisely demonstrated cerebral blood perfusion, but I think it might be the indirect parameter for checking the cerebral blood perfusion. Actually, the onset of LCC, the organ flow pattern in the diastolic phases actually is collapsed. And after the treatment of hydrocortisone, the abnormal flow pattern is recovered. So I think the actually just very easy to check the echo card, but check the cerebral anterior cerebral artery flow pattern. It's a very easy way to detect hyperperfusion, especially in the brain. I think I'm not precisely the like a definition of the parameter or something, but I am so complicated situation. But just to check the organ flow pattern, very easy way. LCC is associated with the neurodevelopment outcome as shown in the slides, CP and the postnatal PVL. So after the onset of LCC is too late for detect of the abnormal findings. So to prevent the abnormal neurodevelopmental outcome, we in advance we should know the cerebral conditions in advance before getting worse.
Okay.
So in one word, I think the situation is looks like a septic shock, hyperdynamic peripheral hyperperfusion.
Mm-hmm.
If we use one word.
Dr. Kusta, I want to talk about hemodynamics LCC.
Sure.
Okay?
Yeah, go ahead.
Okay. In our NICU, there is a little LCC, so I don't have many data of LCC, but in our experience, LCC baby had low SVC flow and small right ventricle and LV ventricle, small heart, and I suggest venous dilatation shock. So in my opinion, septic shock and LCC is slightly different to hemodynamics. So we have cohesion, heart size, RV volume, and SVC flow is important for estimate to venous circulation.
All right, Dr. Kusuda, I think we have covered all the questions and all the comments. Would you like to close this session?